Great. Good morning, ladies and gentlemen. Before we dive into today's program, we would like to bring your attention to several housekeeping announcements. First, we are pleased to share that our conference is actually a remarkable turnout of about 500 on-site audience. So it's been really a good event, and I hope you all have been enjoying networking with each other. At the same time, kindly switch your mobile phones to silent mode to minimize disruptions. Unauthorized photography and videography are not allowed during the event. So I am Dr. Francesca Lim, and I'm a senior consultant here at Singapore General Hospital, and I'll be chairing this session. So if you have any questions or answers, please scan the QR code, and you can actually type it in, or you can actually come forward to the mics and ask your questions. So without much hesitation, please let me introduce our first speaker, Dr. Syed Osman Ahmed, who is a consultant at the Hematology and Bone Marrow Transplant King Faisal Specialist Hospital and Research Center at the Kingdom of Saudi Arabia, and he will be speaking to us today on the complications of CAR T-cell therapy. Dr. Osman, thank you.
Thank you very much, Professor Lim. And I'd like to thank the organizers for giving me the opportunity to present to you today. It's wonderful to be back in Singapore. Wonderful city, wonderful people. So I'll be talking about the complications of CAR T-cell therapy over the next 20 to 25 minutes or so. So these are some of the complications that we encounter when we're treating patients with CAR T-cell therapy that I will be going through. So we've heard some very interesting talks earlier this morning about how to manipulate the graft and how to alter the composition of T cells. And we like T cells in cancer and in the management of hematological malignancies. And we know that the role that they have in the GVL effect. We know how we can further harness their power with checkpoint inhibition and BiTEs, and now with CAR T cells. But we know that the potency of CAR T cells needs to be harnessed. And I'm just going to go to a little story. So that is a picture of Northwood Park Hospital in northwest London. It's an unsightly building, not as glamorous and pretty as some of the buildings you have here in Singapore. And we go back to 2006, where there was a trial being run by a product from T-Genero, being run by a CRO, Parexel, for an antibody called TGN-1412, being run as a phase 1 in healthy volunteers. So that was back in 2006, and nobody knew about this happening till it made its way into the news. That was a headline. A few days after the trial, we saw human guinea pigs explode. 6 taken ill after a drugs trial. So what happened here? So this was an anti-CD28 monoclonal antibody, TGN-1412, that essentially became a super stimulator of the immune system that led to hyperstimulation of the immune system, leading to a cytokine storm. And these patients, one by one, ended up in ICU. That led to a lot of lawsuits and bankruptcies, and led to a lot of hesitation in these trials being initiated. Fast forward another 5 years or so, and we have the story of Emily Whitehead, whose cancer was cured by HIV. That was the headline. And we recall her story, and it's very eloquently given by Steve Gropp when he lectures about how Emily, after receiving her first infusion of the experimental CAR T cell at that time, CTL-019, how she ended up in ICU, and how she required mechanical ventilation and inotropes, and how they were able to do cytokine profiling, and the approval of tocilizumab happened in conjunction with the approval of the tisagenlecleucel. So what is cytokine release syndrome? It's defined as a superphysiological response following any immune therapy that results in the activation or engagement of endogenous or infused T cells and or other immune effector cells. And the symptoms can be progressive, but must include fever, and may include hypotension, capillary leak, and or other end organs function, and usually happens in the first 2 weeks. So what leads to it? And this was work done by Michel Sadelain in New York. And they were able to identify IL-1 as an important mediator. So we saw the IL-6 surge in the CHOP study. But they were also able to identify IL-1 as an important mediator of cytokine release syndrome. And murine models showed that CRS developed within 2 to 3 days. And there was a potentially lethal response, but it was responsive to IL-6 receptor blockade, in addition to IL-1. And it's important to note that the severity of what they found was that the severity is mediated not by the CAR T cells per se, but by recipient macrophages, and that opens the course for therapeutic intervention. So what happened? This was a study by a very nice review by Emma Morris with Michel Sadelain in Nature Reviews that talks about the timeline of CRS and ICANS. So CRS occurs relatively early, followed by the neurotoxicity, and it is after the CRS that you see an increase in the numbers of CAR T cells in the peripheral blood, and these are some of the interleukin cytokines that are associated or that mediate CRS. So we see here IL-6, IL-1, GM-CSF, and this happens in the first surge, and you have the second surge, the phase 3 of CRS. So you get this CRS followed by an ICANS, and when the CRS doesn't resolve, you often get this late HLH kind of picture. So macrophages are central to the pathophysiology of CRS. So as you can see over here, you get recognition of target antigen, activation of the CAR T cells that release these mediators, such as GM-CSF, which is why there was a reservation about giving GM-CSF, especially early on after CAR T cell therapy infusion, interferon gamma and TNF, and that activates the macrophages that then release these mediators that lead to further monocyte recruitment, macrophage activation, and release of further cytokines, and you get this vascular leakage that leads to hypotension, cytokine and chemokine production, and you get the CRS. And some of that then leaks into the CSF, into the nervous system, and then you get ICANS. So there were various grading systems that were implemented in the early trials, but this was then unified in 2018 by Daniel Lee et al. By the APBMT consensus grading for CRS and neurological toxicities, which is what is used now in trials and in the clinical setting. There's a very helpful CAR-Tox application that MD Anderson have made available for clinicians, so I would suggest anyone who's treating patients to use this app. So to just go through that briefly, so this is what we have as a wall poster on the doors of patients having a CAR T cell. So grade 1 is fever only, grade 2 is fever, and hypotension that usually responds to fluids. You don't need inotropes, and or hypoxia that's managed with a low flow nasal cannula. Grade 3 is a fever, so they always have to have a fever. So fever is essential to diagnose CRS. Grade 3 is hypertension requiring a vasopressor and or hypoxia. Grade 4 is when you have hypertension requiring multiple vasopressors. So that patient is going to be in ICU. That patient is also probably going to be in ICU, depending on your setup, and or hypoxia requiring positive pressure as opposed to just sort of a face mask. And this then is how we manage it. So I'm not going to go into all the details, but grade 1 CRS generally doesn't require tocilizumab or IL-6 blockage, though there may be a few patients who may be high risk, in whom we may give either early or preemptive or even prophylactic tocilizumab. Grade 2, you would usually end up using tocilizumab, at least 1 dose. And steroids, I'll come to steroids in a minute, but grade 3 and grade 4 patients would definitely have received tocilizumab, and it's a maximum of 4 doses that we use, a maximum of 3 doses in 24 hours. Now, steroids we haven't generally used in the past because there's always been this concerned that steroids might dampen the proliferation of CAR T cells, but that hasn't necessarily been borne out in studies. And following the cohort 4 and cohort 6 of the Zuma studies, we do use now dexamethasone in patients who are high risk. So we might give prophylactic dexamethasone 10 milligrams prophylactically in high-risk patients, and we may also use it in grade 1 for axi-cel, and we use the NCCN guidelines for this. As you progress with the grading of CRS, you need more and more steroids. Patients who have grade 4 CRS, for example, will be on either 6-hourly dexamethasone 10 milligrams, or they would have had a slug of methylprednisolone 1 to 2 grams. These patients, as we said, will be in ICU, and increasingly we're using other agents such as anakinra and siltuximab. So it's very important to educate the staff, especially the junior staff, as to how to manage this. Usually the guidelines will be an IPP, stuck in some pages of an IPP folder that nobody can find out of hours. So what we do is we put the CRS and ICANS guidelines as opposed to on the doors of our patients who are having CAR T-cell therapy. So in our ward, you can identify patients who are having CAR T-cell therapy because they have these charts on their doors. So it becomes easier. So if there's a resident or a junior doctor on call or a fellow, they can see exactly what they have to do and get on with it, because these things always happen at night, don't they, or a weekend. So we have had previously some precautions about steroids and G-CSF, but we're a bit more liberal about that, and they have instructions about who to call. So up to 87% of patients can get CRS, up to 62% of patients get neurotoxicity. So you need clear pathways. You have to have a multidisciplinary approach, so involve ICU and your neurologists and your infectious diseases physicians. Education and training is very important, and most, at least industry partners who will help set up a CAR T-cell program with you will institute a REMS program, a risk mitigation program, and ensure that staff are educated. And audit and quality is important to ensure that you're doing the right things. So we've looked at CRS and ICANS in our cohorts. So we've actually found that when we compare our CRS and ICANS across other studies, including the registration studies, say for Zuma 1 and Zuma 7, that's all grade CRS. This was for axi-cel. So grade 3 and grade 4 CRS for us was less than 5%, and that was without instituting prophylactic or preemptive steroids. And that's all neurotoxicity. That's for diffuse large B-cell lymphoma. So we actually found that neurotoxicity was relatively lower in our patients, and that's perhaps maybe because we deal with a younger cohort of patients. And so was severe grade 3 to 4 ICANS. So again, it's important to keep an eye on your own outcomes in your institution, and then you might want to say, for example, if you have high rates of severe toxicities, you might want to add in steroids early. So then we come to neurological toxicities. So patients with CAR T-cell therapy can develop serious neurological side effects, up to 40%. That's ICANS is the term given to it, so immune effector cell-associated neurotoxicity syndrome. And so these are some of the features of neurotoxicity, and we made this as we were training and teaching our nurses, so they can get a whole gamut and a whole spectrum of neurological features that wax and wane and sometimes catch you off guard. So they can have speech problems and aphasia. They get impairment of cognitive skills. They can get motor weaknesses, seizures in severe forms, dysgraphia, which is why we always get them to write something and we score that. They can get a tremor, and they can get an altered level of consciousness. And what we found tends to happen is it waxes and wanes. So you might go in at one time in the morning, and they're absolutely fine, and then a few hours later they got these. So the ICE score fluctuates. So we find it very helpful to have a family member with them in the room, so they can report any changes in behavior or changes in speech. And it's amazing how these patients can become completely aphasic. They stop speaking. I'll tell you something interesting, though, that we found. So that we had a patient, for example, who had ICANS grade 3, 4. So the ICE score was like 1, 0. They weren't able to do anything. They weren't able to write. They couldn't understand what you were saying. They weren't having seizures, but they had a really severe neurotoxicity. But at times of lucency, we asked them to say something that they had memorized from childhood. And this was very interesting. And the patient would not answer questions. They could not follow instructions. But then we asked them to say something that we know, for example, in Saudi Arabia, everybody knows since childhood. So a certain prayer. And he rattled it off. But he couldn't do anything else. So it seems like anything that requires a certain level of mentation, they have difficulty doing. So we've adapted, we've got our own scale where we get them to say this prayer if they can say it. So we're a bit less worried. We think that they'll get better. Try it, but follow the Lee scoring and NCCN guidelines for how you manage your patients. So that's the Lee score, and again, we have this on the door as well. So the first thing you need to do is first calculate the ICE score, and that's, we check the orientation, naming, following commands, writing, and attention. Then we calculate the ICANS grade based on the ICE score, and depending on whether or not they have concurrent CRS, we manage them either supportively or with dexamethasone. If they have concurrent tocilizumab, if they have concurrent CRS, we treat them with tocilizumab as well. There is a concern that by giving tocilizumab in early ICANS, if they don't have CRS, you can get a surge because you remove the sink of IL-6. There might be a surge of IL-6. The IL-6 makes its way into the central nervous system and precipitates ICANS. And we've seen that a few times. And we try to avoid tocilizumab and just manage with dexamethasone, especially if you have concurrent grade 1 to 2 CRS with the ICANS. So CAR T-cell therapy can associate all organs of the body, and as the field emerges and as we get more real-world data, more of these side effects are emerging, and we're learning about them more and more. All right. Okay. So there's late bacterial, so one of the most important side effects of CAR T-cell therapy are the infections. And I'll come to that in a minute. About neurotoxicity, there is late neurotoxicity that especially emerged with the myeloma trials. So it's a cluster of movement, cognitive, and personality changes, and especially emerged with the CARTITUDE study. And we've seen some of these. We've seen patients picking out all of their cranial nerves and one patient presenting with every neurological symptom or sign that you can think of, waxing and waning, but then eventually resolving. And occurs a period after CRS and ICANS, and they can be non-responsive to steroids. So coming to infections, infections are one of the main toxicities of CAR T-cell therapy. And that's why you need to have, in conjunction with the infectious diseases folks, a protocol of how you prevent infections and how you manage these. And there's an equal distribution between bacterial and viral causes, especially after BCMA therapy. So these are some of the risk factors: impaired baseline performance status, patients who are heavily pre-treated, you would expect to have a high risk of infections, adult patients, patients who already have immune paresis and low immunoglobulin levels, patients who've had a prior allogeneic therapy, especially if they've had a transplant close to CAR T-cell therapy. And post-CAR T-cell infusion, if they've had severe cytopenias, B-cell aplasia, and cumulative immunomodulatory exposure, so if they've had lots of doses of tocilizumab and steroids. So you need to think about the patient factors and the treatment factors in determining your risk of infections. And you have, similar to bone marrow transplants, you have the early infections that are mainly bacterial, and they have these late infections that could be bacterial and or viral. So we give our patients levofloxacin, and we upgrade to carbapenem if they have a fever. We ensure that they have IVIG replacement therapy, especially if the immunoglobulin IgG level is less than 4 grams per liter. And again, BCMA patients tend to have a higher risk. Fungal infections, so far we found them to be relatively less frequent compared to, say, the allogeneic transplant patients. and they're usually rare beyond the first month, unless it's a patient who's already had a transplant or who's already had, especially a recent transplant, or may have had a prior invasive fungal infection. Again, it's important to have standardized guidelines that you make in conjunction with your ID physicians. CMV is, initially there was a thought that CMV reactivation infection is less of a problem as compared to allogeneic transplants, but there's more data emerging to say that patients who get CMV reactivation can have similar outcomes, or even maybe not worse outcomes, if they have CMV disease post-CAR T-cell therapy. And other viruses we see quite a bit as well, HSV, VZV, and we've seen HHV6 reactivation as well. So it's important to have a vaccination protocol. And this is the schema that we have for outpatient follow-up to ensure that they're on adequate prophylaxis, immunoglobulin replacement therapy, and their vaccinations. ICAT, I'll go through this rather quickly. So ICAT is immune effector cell-associated hematological toxicity. And again, understanding and knowledge of this has developed over the last few years. And it seems like infection and cytopenias are some of the main complications that now we're seeing in CAR T-cell patients, especially after that early phase. And the question is, why should CD19 CAR T-cell cells directed against a B-cell antigen affect the myeloid compartment, leading to neutropenia, thrombocytopenia, and anemia? And there are a number of contributing factors. It might be relapse of the underlying disease, the role of bridging radiotherapy or chemotherapy, a prior CHIP, impaired baseline bone marrow reserve, and the suppressive effect of inflammatory cytokines. And again, so this is a schema. So all of these factors can contribute to immune effector cell-associated hematotoxicity. And again, these prolonged cytopenias predispose the patient to infection and morbidities, and the severity and the length of the cytopenias, again, differs according to the disease and the product used. And a meta-analysis has shown a higher incidence of ICAT in ALL patients. I won't go into this in detail, but there is, I'll direct you to this paper, which is the grading and how to manage this. There's a grading system, there's a risk stratification. The hematotox score predicts recovery from hematopoiesis, and these are the secondary causes that one needs to work up a patient for. So there might be hemophagocytosis or macrophage activation syndrome that might be contributing to it, disease recurrence, or even therapy-related MDS. Therapy, treat the underlying cause. We do use G-CSF, especially beyond 2 weeks. There's some concern about using it earlier, but we're using it certainly after 14 days. And so going on to the other complications, so coagulopathy and hypofibrinogenemia is recognized, especially in a bleeding patient, as is bleeding and thrombosis, and tumor lysis is rare. Now, secondary malignancies, there's a concern about. Just a couple more minutes. And there is a joint EBMT-EHA go-card statement recognizing that there are cases of secondary malignancies, especially of the T-cell malignancies, and patients need to be counseled and consented and monitored for this. But on balance, we have to say that patients still benefit from CAR T-cell therapy, so it shouldn't stop us, that fear shouldn't stop us from proceeding. But again, patients need to be counseled, and you need to have a follow-up and surveillance system in place. There was a paper published by Bruce Levine that I would direct you to that suggests the same. So, a lot of the patients who did develop malignancies had a predisposing clone, and there's work from Australia that confirms that as well. And now I'm just going to go to this important question in closing: non-relapse mortality of CAR T-cell therapy. What is the rate of non-relapse mortality? So it varies across disease entities. So this was a systematic review led by Kay Rajewski and Cordas et al. So it's highest in patients with mantle cell lymphoma, followed by multiple myeloma. So we're talking about 8 to 10% here. large B-cell lymphoma and indolent lymphomas. This was based on 574 cases of mortality in over 2,000 patients. And again, infections. That's what we need to be able to recognize, prevent, and treat effectively, followed by malignancies and cardiovascular and respiratory events. So as you can see, infections are the main cause of non-relapse mortality. So you have to have robust guidelines in place. This is a schedule that we use for assessments post a transplant and how we follow them up. And with that, I'd like to thank you for your attention. Sorry for going a bit over time, and happy to take any questions or delay them. Thank you.
Do you want to remain on stage? You can, yeah. Thank you very much, Dr. Osman, for that very comprehensive presentation. I think we have time for maybe one question from the audience. Great.
Yeah. A very nice and elaborate talk, sir. So are there biomarkers available to predict what type of toxicity can happen, be it a neurological or a systemic CRS?
Okay. So obviously we know IL-6 is central, as is IL-1, to the pathophysiology of CRS, right? Now, different centers will have different capabilities of what kind of cytokine profiling they would be able to do. So there is, for example, a six cytokine profile that some centers may use, but it's not part of the grading or your management algorithm. So I think there's room for research or doing your own in-house analyses. What we use is just IL-6 and ferritin and IL-1 sometimes. CRPs usually go down when you give the tocilizumab, it goes down to 1. But in clinical practice, there isn't, but it's a research question, and I guess we should encourage each other to do cytokine profiling so that we learn more about our patients and develop algorithms and predictive biomarkers for how we can modify our CRS algorithms.
Does it predict a grade 3-4 toxicity, sir? Does it predict grade 3 to 4 CRS or ICANS?
So, for ICANS, yeah. So does severe CRS predict severe ICANS?
No. Does this, I mean, let's say IL-6, does it predict severe toxicities?
There is some data to suggest it might, but there are other data that suggest they don't. We looked at it, and it doesn't seem, we've seen really, marked surges of IL-6 that resolve that don't necessarily predict severe CRS.
Thank you.
Okay.
Maybe if you want to ask the question directly to our speaker after the talk. Yeah, sorry about that. Thank you. Great. Okay, so our next speaker is Dr. Peggy Liu. She graduated from Beijing University Medical School and completed her residency at the University of Nebraska Medical Center. She completed her fellowship in hematology and oncology at Stanford University Medical Center. Dr. Peggy has received many awards, including National Cancer Institute Individual Fellowship Award and the Physician Scientist Award from National Cancer Institute. And today, Dr. Peggy will be sharing with us on real-world data of academic CAR T cell therapies in China. Thank you, Dr. Liu.
Good morning, everyone. First, thank you for your kind introduction, and also thank you very much for the invitation. It is a true honor to be here. So my topic today will be a little bit different than the previous listed. So today I'm going to focus more to talk about CD7 CAR T therapy for treating TLL, TLBL. So as you all know, the CAR T therapy for treating B-cell malignancy has become more and more mature, and multiple products has been commercialized. However, CAR T treatment for T-cell malignancy are still in the relative early stage of clinical trial. So it poses a different challenge. You can see due to the shared antigen expression on CAR T cell and malignant cell, so it could induce potentially CAR T cell fratricide. And a CAR T cell could also target normal T cell, NK cell, so may result in T cell aplasia. Potentially worry is increasing the infection rate. The other is manufacture CAR T involves isolating normal T cells, especially for those autologous CAR T cells, and especially for patient. If you have like a TLL patient, often they have a very high blast counts in their peripheral blood, so manufacture could be a potential problematic. So we actually developed a novel agent. We call it naturally selected CD7 CAR T therapy without needing for any genetic manipulation for treating TLL, LBL. Our first phase 1 clinical trial published 2 years ago involving 20 patients. Obviously, 20 patients is not enough. So last year, we published another 60 patients treated with this CAR T. So I'm going to more focus on today's talk. So what it is, the NS7 CAR, it is a second generation of CAR T products with 4-1BB as a co-stimulator. So the bulk T cell can transduce with a CD7 CAR without gene editing or additional gene transfer. So you can see actually 3 days after transduction, T cell will have a rapid and dramatic phenotypic transition from CD7 positive CAR negative to the CD7 negative CAR positive by flow analysis. However, the CD7 protein and mRNA expression actually is still present in those cells. If you analyze by Western blot or RT-PCR, you can see those are still there. Therefore, it indicated that fratricide resistance was achieved by CAR-mediated CD7 epitope masking or by intracellular sequestration of the CD7 protein. So let's focus on those 60 patients. So for the total, those 60 patients received this CD7 CAR T therapy. You can see the 35 of those belong to TLL, and the 25 patient will belong to TLBL. Median age is 19, from 2 years old all the way to 47. And the median bone marrow blast was 4.42. However, up to 88%. People say, hey, your median was only 4.42, but remember, majority of those patients belong to TLBL patients. They all have extramedullary disease involvement. And actually, more than 25% of those patients have the bone marrow blast count blast counts more than 25%. And the other, quite a few patients actually had their blast counts in the peripheral blood more than 30%. One patient even had a blast counts in their peripheral blood up to 62%, and we still able to do the successful manufacture. And the median prior line of therapy was 5. And you can see more than half of patients all have extramedullary disease involvement, including CNS involvement, and And some of patients have localized, however, often on those localized patients have a very bulky mediastinal involvement. And then quite a few patients have diffuse body involvement. And 22% of those patients actually relapse from previous allotransplantation before the CAR T therapy. And then the 30% of patients belong to the ETP group. Other patients have, such as the still fusion gene, TP53 mutation, etc. So those are really very high-risk patients with heavily pretreated group of patients. So we have a 98.5% manufacture success rate. Every patient, each patient receiving only one single dose of infusion. So now let's take a look at the 4 weeks after CAR T infusion for the evaluation. So first, let's take a look at those bone marrow evaluation. So 94.4% of those patients actually able to achieve MRD negative CR/CRi in their bone marrow. And one patient had MRD positive CR. This patient actually was found to have lost CD7, and 2 showed no response. 1 also found to have lost CD7. 6 TLBL patients without bone marrow blast at enrollment remained MRD negative. And then for the extramedullary disease involvement, you can see for the 32 patients with extramedullary disease, the ORR up to 78 and 56% achieved complete remission, and 22% achieved PR. This is a representative cases, patient with TLBL. You can see before the CAR T therapy, this patient really have a very bulky disease involving bilateral breast, mediastinal, pleural space, etc. So really very sick. This is the 1 month after CAR T therapy, this patient really achieved complete remission. This is another represented cases of with CNS involvement. On day 8, LP still showed that the 37% CD7 positive malignant cells. At that time, no CAR T cell detected yet. On day 14, you can see it already able to detect 12% of a CAR T cell. And that time, the malignant cell already eliminated. So what about the longer term survival? So the median follow-up was 369 days up to 833 days. The 2 years OS progression-free survival was 63 and 53.7 for the total 60 patients respectively. Then the subgroup, 47 CR patients, 7 out of those 47 patients after CAR T therapy subsequently had a consolidation allotransplantation and 10 without. You can see the 1 year OS shows no significant difference. However, the 1 year OS was significant difference, significantly better for those patients up to 67% who had a consolidation transplantation after CAR T. For the 10 patients without the consolidation transplant, 8 patients relapsed within 150 days and 2 remained disease-free in 128 and day 180. So it looks like transplants do play an important role. Then let's take a look at the subgroup analysis. For our pediatric patients, age less than 14 versus older than 14 shows no significant difference between OS and PFS. And there's also no significant changes in terms of OS, PFS regarding the different dose group. For the ETP patient, for ETP versus non-ETP patient, again, shows no statistical significance. Patient with extramedullary disease and showed again, also showed a trend, probably better, but again, for those without extramedullary disease, however, no statistical significance. For patients with a lower disease burden in the bone marrow, less than 5% versus higher or equal than 5%, you can see the 1-year OS was towards better for a lower leukemia burden. However, no statistical significance for PFS. And a patient who had a prior allotransplantation before CAR T therapy demonstrated a lower OS at 1 year, 49 versus 78, and PFS 1 year was 30% versus 66 with a P significance. And the other is when comparing the 6 patients with still tau1 fusion gene versus without, there is statistically significant, much worse for those patients with still tau fusion gene. And you can see actually 4 out of 6 those patients relapsed within 3 months, and 2 out of 4 those relapsed patients were found to have a CD7 loss expression. And also 4 patients with TCR-AD MYC translocation also showed a significantly worse OS and PFS compared to those people without. So what about a patient with complex cytogenetic abnormality? Once more, the 1-year OS was 30% versus 79% for those with complex cytogenetic abnormality, and also same as true for the progression-free survival, so much worse for those with complex cytogenetic abnormality. And the 6 patients with TP53 mutation and also showed a significant lower OS. So the in vivo CAR T cell expansion were carefully monitored both by qPCR and the flow, and you can see the median peak time was day 14, similar for the flow. And in terms of persistency, because majority of our patients pursued allotransplantation, so it's hard to give a detailed data. However, patients without transplant up to 120 days still able to detect. And 53 out of 60 patients, we also have available CAR T cell expansion data in CSF. The majority of patients, however, only tested once because it's difficult to test multiple times. The median maximum level of NS7 CAR T in CSF was 23%, and among the 10 patients with CNS involvement, the median maximum level of NS7 CAR T was 22%, so it's no significant difference. So what about the safety? Majority of our patients, 80% of our patients only have a mild CRS, grade 1 or grade 2. Only 10% of patients had a grade 3 CRS, and 1 patient had a grade 4 CRS. And 2 patients had a grade 1 ICANS, and only 1 patient had a grade 4 neurotoxicity. So this is, generally speaking, is very well tolerated products. And the patient always question, people always question about it. How about your NK and T cell after CAR T therapy? What they're going to show? What we find out is the absolute number of the T cell actually show a transient decline to a different level. Then they bounce back, and we find out that the activity of NS7 CAR T can induce rapid ablation of CD7 positive cell, which would then promotely replenish by CD7 negative normal subsets. What showed here is bounce down was all due to those patients had a transplant. What about infection? And so for our total 60 patient, about 16.7 patient experienced a grade 3 infection, and 8 patients had a lung infection. Those number does not appear to be higher than our historical control. And two patients had a CMV reactivation, and 3 patients had EBV reactivation, all able to be well controlled. And then 37 out of 60 patients received the consolidation allotransplantation, including 29 was haplotransplant, 8 was match unrelated, and 6 received a second transplant because those patients was relapsed from their first transplant. And you can see the GVHD incidence are listed here, and also does not appear to be significantly higher than our control. So what about the safety and the outcome of allotransplantation in TALL-LBL patient after CD7 CAR T versus after the chemotherapy? We did a parallel comparison. Sorry. We have a total 223 patients during this period of time. You can see the CR induced by chemotherapy total 124 days, and before the transplant, and also breaking down CR1 before transplant, and CR2 and more before transplantation. And also total 43 patient was refractory relapse patient receive CD7 CAR T therapy before transplant. And we even excluded all those patients with less than 5% of blast, although so down to the 34 patient did a comparison. For the total 158 patients, you can see the OS and leukemia-free survival for the 2 years was 61 and 65.8% respectively. The 2 years non-relapse mortality and relapse incidence for all those 158 patients also listed here. We then breaking down into the different group, and you can see the 2-year leukemia-free survival was 63.3% in CAR T group, 69 in CR1, the chemo group, then had a transplant, and only 33% in those patients CR2 patient before their transplant. And the same also similar data showed on the OS. And in terms of 2 years relapse incidence, again, 8.8 in CAR T, 11.5 in CR1 group, and 31.6 in CR2 group. And our 2 years non-relapse mortality is 32 in CAR T, 21.6 in CR1 and 38.6 in CR2. So those are no significant difference. But again, you can see the refractory relapse patient, if they able to achieve complete remission, then have a chemotherapy, then have the bone marrow transplantation, their outcome can be as good as for those patients chemo-sensitive patient, they able to achieve CR1 from chemotherapy, then had a consolidation allotransplantation. So the 2 group patients even have a very good, comparable results, 2-year results. So conclusion, so we developed those novel methods to generate those anti-CD7 CAR T without additional genetic manipulation. So our phase 1/2 study showed really the NS7 CAR-T is safe and highly effective in patients with heavily pretreated patients. Certain high-risk group of patients have a little relative poor outcome. When relapse, we find out about 1/3 of patients will show have a CD7 expression loss. A majority of patients actually only experience mild CRS and neurotoxicity. So while we all are amazed about the CAR-T, the good results, now CAR-T even move beyond the malignancy. So we all are familiar about the CAR-T for treating autoimmune disease. Now CAR-T even have a paper for treating heart failure, fibrosis, and now a few papers even say that CAR-T can eliminate aging cells. So maybe in the future, if we're able to decrease our CAR-T toxicity, maybe we are able to, for our, we all need that for our longevity. Just a few words about our institute. We are a private hematology institute in China, and we do quite a lot of bone marrow transplantation. Last year alone, we performed 1,493 transplants. Majority of those, 99% are allotransplantation, and more than 70% belong to haplotransplant. The other is 10 or little more are match and related transplant because of one-child policy for many years, so we have to do this. And about 10% or more, little more was belong to the sibling transplant. We've been doing CAR-T clinical trial since 2015. Those are cases we completed each year. People talk about to take the whole village, really do the CAR-T clinical trial, and this is our team. We are very proud of our team. And again, thank you very much for your attention.
Great. Thank you so much, Dr. Liu, for that very, very exciting presentation. Question from Dr. Huang.
Hi, Dr. Liu. Thank you for an excellent presentation and excellent work done. I find your work of the CD7 CAR-T cells that don't have fratricide interesting, because there are a number of groups trying to solve the fratricide problem. For example, there's work by Dario Campana's group using a CD7 protein expression blocker published recently in Nature Medicine. But in your work, your CAR-T cells, anti-CD7 CAR-T cells, do not seem to demonstrate this fratricide due to a downregulation of CD7 on the surface of the CAR-T cells themselves, naturally occurring. So is this a natural consequence of natural selection of the CAR-T cells that downregulate the CD7 expression? And is it going to happen in any CAR against CD7? Or is it some special manipulation you did in the transfection process or otherwise?
Yeah, that's a good question. So what we find out, we all worry about, fratricide, especially at the very beginning, we all worry about fratricide. So there's a number of the methods to generate those CAR-T to avoid fratricide. One is certainly that you mentioned using the protein blockade. The other is CRISPR-Cas9 editing technology. And third one is universal CAR. And our one is we call it novel because we find out we don't even need to do any manipulation. We find out after the 3 days of a culture, they just, you can see it by flow cytometry that you're no longer able to detect their surfacing CD7. Actually, the protein actually still there by Western blot or qPCR. What we propose, we think those CAR-T have a dual function. One of the function is they're able to interact with other cells antigen that we call the trans interaction. On the other hand, they're able to interact their own antigen, CAR own antigen, we call the cis interaction. Those trans and cis interaction actually well recognized, published in the past for other. And we think that our NS7 CAR have those dual function. And in terms of why we have a lower toxicity than other, because our clinical trial are different from the regular clinical trial. Even though we're phase 1 clinical trial, we recognize those are living cell. So a lot of clinical trial design is they use the 3 dose, lower dose, medium dose, or higher dose. After a certain number of lower dose, they move on to the medium dose, then they move on the higher dose. So we design our treatment, we give the 3 dose. Certainly first clinical trial, first dose need to be start with in the lower dose. After that, we give our team an option. We design the choosing the dose, what dose to give is based on patients' performance status and their tumor burden. For example, if you have a patient have a very high leukemia burden, if you have 88% of blast counts or 60% of peripheral blast counts in the peripheral blast, we try not to use very high dose of CAR T cell, because if you use very high dose CAR T cell, those patients end up to have a very high side effects. On the other hand, if I have a patient have relatively low CAR T, relatively low blast count, 5% or lower, I may want to use a higher count. So it's different. Use a higher count, and typically those patients will have less side effects. So those are, we call that performance based, performance and tumor burden based strategy, how you are picking up, choosing the dose. The other strategy we using as, we know the standard is you do not give any prophylactic treatment until grade 2. Our approach is if you have a patient have a persistent fever, 39 or higher, persistent more than 1 day, even they are still belong to the grade 1, we start to give them 2C or plus minus steroids. And we do not think that to really interfere with our outcomes. So perhaps that's the reason we're able to decrease overall toxicity too.
Thank you so much.
Great, another question.
Thank you for your excellent presentation. In your presentation, in your country, we will perform many CAR T cell and hepatopoietic stem cell presentation. I have one question about the young mantle cell lymphoma with the very high risk. For example, the patient have the TB53 mutation positive. The question is, if the patient receive the PR or CR after the chemotherapy, what should you do? You give the patient the rituximab maintenance treatment, or you give the patient the allogeneic stem cell transplantation, or you give the patient the CAR T cell? Because according to the recent guideline, not the indication for the autologous stem cell transplantation in the young mantle cell lymphoma, very rich, very high risk.
You talk about, I'm sorry, I not quite get the question. You talk about mantle cell?
Yeah, mantle cell lymphoma.
Mantle cell lymphoma patient?
Yeah.
Oh, how we are going to approach our mantle cell lymphoma patients?
Yeah, the question is for the younger mantle cell lymphoma patient with a very high risk. For example, the patient have
whether we are going to move early.
After the chemotherapy, if patient receive the PR or CR, what should you do? For the CAR T cell or the allogeneic stem cell or the rituximab maintenance?
Right. Those are certainly very great, question, we face on day by day for our clinical practice, how you're going to choose whether you're going to move your CAR T more upfront or whatever. And so for certainly also depends whether that patient also is receiving commercialized CAR T products, or actually they're still under the clinical trials. And under the clinical trial, typically still in China, we still design, you have to fail at least 2 products before you can do. And for the commercialized, actually, currently, I tell you our experience, because the not covered by insurance. So if you move very, very upfront, and also troublesome because a lot of patients may not have that kind of the financial support able to do that. So we have to be very careful. That's actually situation in China. But personally, I think in the future, and I think for very high risk patient, you can, consider, and often we are, as a clinician, consider to move the CAR T therapy in earlier, stage of that. Yeah.
Thank you very much.
Great, thank you very much, Dr. Liu.
Thank you.
Okay, this is much better. I look taller now. Anyway, so I think there'll be many more questions for Dr. Liu after this session, because it is really exciting. I myself have some questions, but I'll save that for after the session as well. So the next speaker is Dr. Jenny Liu. She's a medical oncologist specializing in drug development and early phase clinical trials, as well as the head and neck cancer at the Kinghorn Cancer Center, St. Vincent's Hospital, Sydney. She cares for patients with advanced and often treatment-refractory cancers who lack standard of care options, and enrolls patients into clinical trials for these novel therapies. And therefore, without much further ado, she's not here with us physically, so we'll actually be watching a video, but she will come on live after that to address any of the questions from the crowd. Thank you.
Good morning. Thank you so much to the organising committee for inviting me to talk today at the 2024 APBMT conference. I'm very sorry I can't be there in person with you in lovely Singapore, but hopefully you'll find my talk relevant and interesting. So my name's Dr. Jenny Liu. I'm a medical oncologist at St. Vincent's Hospital based in Sydney, and I'll be talking about engineering cellular therapies for solid tumours. These are my disclosures. So in my talk today, I'll be starting by overviewing the landscape of drug development in solid tumor malignancy, the challenges of solid tumor CAR T, and some engineering strategies that have been utilized to tackle these challenges, as well as engineering strategies beyond CAR T at some novel cellular therapies that are having emerging efficacy in different tumor types. And finally, I'll be describing our process by which we set up institutional readiness for conducting solid tumor cellular therapies. Over the last few decades, we have seen a revolutionary increase in our understanding of the mechanisms by which cancer proliferates, and as a consequence, there has been also an explosion of targeted therapies, immunotherapies, and cellular therapies designed to target these hallmarks of cancer. In hematology, as you are all very aware, cell therapy has revolutionized outcomes, and patients initially treated with CAR T remain alive and cancer-free today. However, in advanced solid malignancies such as colorectal cancer, despite a large number of trials looking at combination chemotherapy, as well as targeted therapy, for example, for those with BRAF mutant colorectal cancers, outcomes remain overall fairly dismal. And a review of 150 phase 3 trials conducted from 1986 to 2016 showed that only 26.5% resulted in any meaningful improvement in overall survival. And as such, as a solid tumor drug developer, we look with much envy at our colleagues giving hematology CAR-Ts in terms of really the lack of efficacy seen to date and the need for more potent and promising cellular therapy products. This has likely also been the driving factor behind industry with the rapid explosion of multiple products targeting cell and gene therapies, antibody drug conjugates, and multi-specific antibodies occurring in the drug development space in the last 10 years. However, CAR-Ts do face many challenges when administered to solid tumors. We can liken this as a castle that is very strongly reinforced. Large tumors often have a very cold tumor microenvironment with poor trafficking of CAR-Ts into the tumor. This is often mediated by immunosuppressive cells such as cancer-associated fibroblasts, T regulatory cells, M2 macrophages, as well as immunosuppressive cytokines released within the microenvironment. This leads to poor T cell function and exhaustion and often short-lived responses. There have been a number of engineering strategies that have been used to tackle these barriers in solid tumor CAR-Ts, addressing on-target off-tumor toxicities that occur when the target for the CAR-T is also expressed in normal tissues, leading to significant risk of toxicity. In addition, because of heterogeneity in the target, antigen escape and acquired resistance can be a frequent problem. And as mentioned before, trafficking, infiltration, and the immunosuppressive microenvironment can pose significant barriers. One approach to targeting this is logic gating. For example, in solid tumor CAR-Ts, some have been designed to express and target CEA, which is present in many cancers, such as colorectal cancer, but there can be normal expression of CEA also in the lung, gut, and skin that has led to life-threatening toxicities such as pneumonitis. Logic gating is targeting tumor-restricted post-translational modifications, which is designed to restrict the CAR-T activation to tumor cells only. In the setting of the OR gate, if a tumor has two targets, A and B, the T cells can co-express a CAR specific for antigen A as well as for antigen B to overcome the issue of heterogeneity. In panel B, the AND gate, the CAR T cells are fully activated when the CAR and the CCR simultaneously engage with antigens A and B co-expressed on the tumor, but not on normal cells. And then in the NOT gate, T cells co-express a functional CAR specific for antigen A and an inhibitory CAR specific for antigen B. And they're activated when the CAR engages with antigen A expressed exclusively on tumor cells, and the ICAR engagement with antigen B expressed on normal cells reversibly inhibits these CAR-Ts. One real-life example of a logic-gated CAR-T trial currently open is the trial Everest-1, where patients are infused an autologous logic-gated CEA-targeted CAR-T cell that addresses the challenges of on-target off-tumor toxicity by combining a CAR activating receptor with a blocker to discriminate tumor from normal cells. And the activator recognizes CEA on the surface of tumors and normal cells, while specifically the tumor cell is provided a blocker that binds to HLA-A02. Another approach to address toxicity is engineering an off-switch. Overall, though, studies have shown that the prevalence of CRS and ICANS is lower in solid tumor CAR-Ts compared to hematology trials, where grade 3 CRS has been found to occur in 3.8% compared to 7.3% in hematology trials, and ICANS rates of 2.3% compared to over 10% in heme trials. Alternatively, CARs can encompass 4-1BB costimulatory domains, which are associated with less toxicity than the CD28 costimulatory domain. With regards to the off switch, this can occur through a variety of mechanisms. For example, we can engineer the CAR-T to express a protein like EGFR, and then if we need to switch off the CAR-T, infuse an EGFR monoclonal antibody such as cetuximab, which binds to EGFR and then causes antibody-dependent cellular cytotoxicity. An alternative way is also infusion of ICASP, which then with administration of a medication to then induce apoptosis and activation of downstream caspase molecules can result in apoptosis of the CAR-T. And then thirdly, a suicide switch can be engineered with herpes simplex virus family kinase and then infusion of ganciclovir to form toxic triphosphate in the DNA, leading to cell death. One way to address the problem of antigen escape and immunosuppressive microenvironment is the design of tandem CARs, or multiple antigens targeting, for example, HER2 and MUC1 in breast cancer, or mesothelin and folate receptor 1 in ovarian cancer. Armored CARs are a way of engineering a CAR T cell to be resistant to immunosuppressive signals, such as CAR Ts armored with a dominant negative TGF-beta receptor, but targeting PSMA in men with castrate-resistant prostate cancer. And this trial, published in Nature Medicine a few years ago, showed a CAR T which did have some promising efficacy signals in heavily pretreated men with prostate cancer, with also RECIST responses, although one patient, number 9, whilst they had a deep PSA response, did succumb due to toxicity from the CAR T trial. In terms of addressing trafficking and infiltration, CAR Ts can be engineered to secrete VEGF. Alternatively, we can inject CAR Ts, for example, into the intraventricular system for brain tumors, and also engineered to overexpress certain tumor-derived cytokines, such as CXCR1 or CXCR2. Finally, studies are now underway combining CAR Ts with checkpoint inhibitors as well as oncolytic viruses. One example of an emerging CAR T success story is that targeting Claudin 18.2, which was presented at the major oncology meeting ASCO this year and also published in Nature Medicine. Claudin 18.2 is a normal tight junction protein that's present in the gastric epithelia. However, its expression becomes aberrant on the tumor cell surface during malignant transformation, making it a promising therapeutic target in a range of upper GI cancers, including stomach cancer and pancreas cancer. In this trial, the CT041 is an autologous Claudin 18.2 directed CAR T therapy where the chimeric antigen receptor comprises a humanized anti-Claudin 18.2 single-chain variable fragment, CD8 hinge region, CD28 co-stimulatory domain, and then the activating domain. In this trial, patients that were heavily pretreated, that were Claudin 18.2 positive, underwent apheresis and were allowed bridging chemotherapy during manufacture. They then underwent lymphodepleting chemotherapy in single infusion, and in 98 patients that were enrolled, the majority gastric and gastroesophageal, rates of toxicity such as CRS were low and almost all were grade 1 to 2 with no cases of ICANS seen. There were 8% of gastric mucosal injuries expected to be on target of tumor toxicity, but only one case that was grade 3. You can see on the waterfall and swimmers plots the very promising efficacy, objective response rate close to 40%, and in gastric cancer specifically, objective response is 55%. However, the duration of response was fairly short at 5.8 months, and overall survival only at 9 months. So the stability and perseverance of the CAR T remains a problem that is warranting further investigation. Beyond CAR T, there are a number of other approaches of adoptive T cell therapies, which I'll briefly describe as well. And this, I guess, reflects the challenge with engineering CAR T for solid tumors in the fact that to date, there are no FDA approvals yet of a solid tumor CAR T. A Afami-cel is an engineered T cell that binds the MAGE-A4 peptide that's presented by HLA-A02 antigen-presenting cells. And MAGE-A4 is a melanoma-associated antigen that is an intracellular protein expressed in a range of solid tumors, including synovial sarcoma, liposarcoma, lung, and head and neck cancer. As MAGE-A4 is intracellularly processed, it presents peptide fragments that are co-presented with HLA on the T cell surface, forming epitopes. And so this product is an autologous engineered T cell receptor transduced via a lentiviral vector to express the T cell receptor targeting the peptide presented by HLA. In this trial, over 800 patients needed to be pre-screened to be HLA eligible. 200 patients were then MAGE-A positive, and then only 63 patients were enrolled to intention to treat, of which 60 underwent leukapheresis and then 38 eventually treated with the IP. In the intention to treat population, the objective response overall was 24%, but in the sarcoma population, response rate was quite promising at 44%, with a median duration response of 7 months. There were some cases of CRS, 55%, with 4 grade 3 to 4, and 2 cases of ICANS. Based upon this trial, the product has received accelerated FDA approval, but I guess some of the challenges in terms of the number of patients needing to be screened in order to treat patients makes sustainability of a product like this somewhat challenging, especially if the responses are not durable. And I guess because this is an Asia Pacific meeting, really highlighting the fact also that HLA is restricted therapies is not universally beneficial for all different ethnic populations. This HLA is a lot more common in patients of European descent and less common in patients of Asian descent. And we do need to engineer products that are likely to benefit patients of all different ethnicities. Another approach beyond CAR T is that of tumor infiltrating lymphocytes. And lifileucel, an example of an autologous TIL, a cellular therapy that has had traction in unresectable metastatic melanoma. So in this trial, patients' TILs are obtained from a tumor resection or a biopsy and then expanded in ex vivo with the infusion of IL-2. The expanded and activated T cells are then reinfused into patients who are given low-dose IL-2 after low-dose Cy/Flu lymphodepleting chemotherapy. And in this trial, some cytopenias, infusion-related reactions, and hypotension was seen. There was a promising response rate, 31%. Median duration response was not reached at the time of data cutoff, and some durable responses as well, with 42% having a response greater than 18 months. This product has also received accelerated FDA approval, and there is currently many trials ongoing, including phase 3 trials in melanoma and phase 2 trials in lung cancer, which our hospital is currently undergoing activation to expand and test this product in different settings. Finally, I'd like to overview some of the CAR T efforts that are currently open at St. Vincent's Hospital in Darlinghurst, where I work. And we were fortunately selected to participate in a LGR5 targeting CAR T trial for colorectal cancer patients. This is one of the more first generation CAR T products, but it does have an engineered EGFR off switch where we can use cetuximab to turn the CAR T off if a patient has severe toxicity. Additionally, we are currently enrolling to a trial where there is a CAR-like mRNA, which is infused in patients, and it causes in vivo reprogramming of myeloid cells to express TROP2 and then target TROP2 cancers. And these in vivo CAR-like trials do not require apheresis or lymphodepletion, so logistically become easier, although the patients do need ongoing infusions Q2 weekly. In terms of establishing institutional readiness for those in the audience who may be interested in setting up CAR-T at your site, this was quite I guess, an engaged process. Because we had not previously done solid tumor CAR-T, we first of all visited Peter MacCallum Cancer Centre, which has an established solid tumor CAR-T program, to learn from their processes. We partnered very closely with our hematology colleagues to align the trial processes alongside their standard of care and other patients requiring CAR-T and transplant. We conducted hospital-wide education on toxicity management with intensive care, emergency, hematology, oncology, and repeated this when a patient was enrolled and about to be dosed. And then we also maintained a very diligent waitlist process so that a large number of patients confirmed LGR5 positive would be ready and potentially able to enroll. We successfully dosed our first patient in July of this year, and she remains well without progression 3 months after dosing. And we've also established a hospital-wide procedure for management of toxicity associated with CAR-T products on clinical trials. And now there are several CAR-T as well as other novel cellular therapies in autoimmune diseases and other cancers that are opening at St. Vincent's Hospital. So in conclusion, I hope my talk has shown you that cell therapy is a rapidly growing area in solid tumor drug development, and engineering strategies are required to increase CAR-T persistence and penetration in solid tumors. There are also lots of efforts beyond CAR-T in terms of T-cell receptor and TILs, which are currently receiving accelerated FDA approval, and close collaboration is really required for institutional setup, safe administration, and toxicity management. On this front, within the early phase drug development unit at St. Vincent's Hospital, we have a network of clinicians across all different specialties that we call our toxicity management dream team. And we're very privileged to have these clinicians and experts at our fingertips to help our patients with toxicities that occur whilst on trial. And finally, if we do make progress in the setting of solid tumor cell therapy, given the high numbers of patients with cancer, equity of access will be challenging. So I'd like to close by acknowledging all patients and carers for their contribution on trials, the phenomenal early phase trials team, as well as the hematologists, apheresis staff, stem cell staff, as well as our trials pharmacy for their contribution in enrollment on our trials to date. Thanks very much, and I'll be delighted to join you for questions at the end of the session.
Thank you, Dr. Liu, for that presentation. I'd now like to invite you to join us for the live Q&A session, please. Jenny, sorry, great, we can see you now. Thank you for joining us. I think that was a slight technical glitch. Thanks for your presentation. Any questions from the audience? Dr. Huang.
Hi, sorry. Jenny, great presentation. I'd just like to ask, how do you manage the relationships between the solid tumor oncologists, the hematology team, the lab, and otherwise, so that you get the solid tumor folks involved, but at the same time, everything works well?
That's a very great question, and my colleagues, Professor Moore, I think Professor Ma are in the audience. So certainly, I think close collaboration is really key for setting up solid tumor CAR-T, and we did this very cautiously and slowly. As part of the trial, because this is a first-in-human product, enrollment is very staggered from the sponsor side as well. with only one patient able to be dosed at a time, and there's a 28-day dose-limiting toxicity window. So in fact, we aren't able to enroll lots of patients. So as such, we have planned and attended the regular hematology meetings to understand what the capacity of the apheresis, the cell lab, as well as, I guess, the ward is, so that we can then align a time that is suitable. So this is where it's also very important that we have very fit and well patients that are selected, I guess, for enrollment on the trial. This is going to be, I guess, a problem if this CAR T is found to be effective, because the selection bias of the types of patients we're able to put on this trial, I guess the median age of the patients at the moment we have screened is probably around 40 to 50, whereas most bowel cancer patients are more 60 and 70 and probably have more comorbidities and more rapid disease progression and can't wait the 6 weeks between apheresis and then infusion. But I guess in summary, it's really about close collaboration and aligning our processes so that we don't interrupt too much with the standard of care that's occurring within a very busy hematology unit.
Thank you, Dr. Liu. Any other questions from the crowd, from the audience? I have a question as well. At our institution, we are actually going to start the TIL, the tumor infiltrating lymphocyte trial in melanoma and in lung cancer patients. And knowing that probably your center has experiences, is there anything that maybe you could give some wisdom or advice to the hematologists who are supporting the oncologists to conduct this clinical trial here at National Cancer Center and SGH?
Thanks so much, Professor Lim. And actually, we are in startup at the moment, so we haven't yet dosed a patient with TIL therapy. But I guess this is something that we're actively discussing with our intensive care unit, mainly because of the repeated doses of IL-2. There is a 10% risk of quite severe hypotension, infusion-related reactions, and then these patients will probably need inotropic support. But having all the patients having TILs have a mandated ICU bed can be somewhat challenging. At the moment, it looks like to begin with, we will probably have the patients electively admitted into ICU and then going from there, seeing what our experience is. And I guess if we develop more confidence or are able to, I guess, activate the ICU team as needed, we might not need the sort of elective ICU bed.
Great, thank you. And maybe just on the TIL question again, do you all work closely with some surgeons to excise that tumor? And is that a joint decision between the oncologists and the surgeons? And who takes ownership of that tissue that has been minced up and sent to the manufacturing site overseas? Because that doesn't involve the stem cell lab, I believe.
Yes, that's right. So when we excise those specimens, I guess, I think core biopsies is also allowed, but that process I don't think will require the stem cell lab. I anticipate this is going to be occurring in the context of the lung multidisciplinary team meetings. So at the MDTs, there are a few very engaged and academic surgeons at our institute who our lung oncologists collaborate closely with. And for that TIL study, it will be a lung oncologist being the principal investigator on the trial rather than myself, where I sort of see all cancer types in the early phase setting. So she will be sort of driving that initiative, but in collaboration, I guess, with hematology in terms of the Cy/Flu chemotherapy and also with the early phase trial unit for support and toxicity management.
Great, thank you. Any other questions? Okay, so thanks very much, Dr. Liu, for joining us virtually. Hope to see you soon physically in person.
Okay.
Okay, great. So thank you everybody for attending this session. I would like to thank all our panelists for this enriching and sharing and addressing the questions from the audience. Several points to mention. First is lunch break. Everybody's very happy, that's great. But we will have 2 lunch symposium, one sponsored by Kite Gilead and another sponsored by Johnson & Johnson. The Kite Gilead will be starting at 12:30, and we will be discussing optimizing DLBCL treatment journey in the Asian Pacific every step of the way. And this will happen here physically in this auditorium. The J&J lunch symposium will also start at 12:30 on the topic of how to manage a triple-class exposed relapsed refractory multiple myeloma patient with T-cell engagers. And that will take place in the seminar room outside L1S1. There's also a nursing session, session 4, and that's taking place a little bit early. Oh, no, we'll be starting at 1 p.m. And that will take place as well outside L1S3. And the most important announcement that I have been mandated and ordered to give to all of you is that tonight there is a gala dinner, guys. So please, there are shuttles that will leave level 1 outside here at 5:50 p.m. I hope to see all of you there. Thank you.